Valsalva test.
Okay, Valsalva test. Patient is going to be seated in a good upright posture. Clinician's going to be along the side. How to perform the test? I'm going to do one of two things. I'm going to either ask the patient to simulate a bowel movement. Please don't have it. Or if they are apprehensive about that, you can ask them to go ahead and blow into a closed fist like this. Go ahead and do that. Okay. So what this is doing is it is increasing the intrathecal, extrathecal pressure. We are looking for a space-occupying lesion like a osteophyte, tumor, disc herniation, narrowing of the foramen, and the symptoms that the patient would express is a reproduction of the neurological symptoms, either going in a radicular or bilateral pathway. What's next?
Milgram test.
Patient is going to be supine. So it can be up all the way on the table, just a little bit. That's fine right there. Arms at their side, completely relaxed. Clinician is going to be alongside the patient. What I am going to ask the patient to do with their knees extended, I'm going to ask them to flex both hips so their feet are about 6 inches off the table. And I'm going to have him hold this position for approximately 30 seconds. You can relax. Positive finding is the patient is unable to hold that position. However, he is unable to hold it due to low back pain or reproduction of the neurological symptoms. If he cannot hold it due to weak abdominals, that is not a positive finding. And what this is looking for, he is increasing the intra and extrathecal pressure that would be suspicious of a space-occupying lesion, such as a tumor, osteophyte, disc herniation, or narrowing of the foramen. I think I said it before, so his symptoms is a reproduction of either the low back pain or the radicular symptoms.
Quadrant test.
Quadrant test. All right, Adelsar, you're going to be standing. You can stay there. So let's have you stand facing that way. Okay? You're going to have your feet shoulder width apart. You're going to put your hands on your hips. Did you say quadrant? Is that right?
Yes.
Okay. So clinician is going to be behind the patient. I'm going to ask him to perform 3 different motions. I am assisting to give him overpressure. So his hands are on his hips to keep his hips in this position, so don't turn. I want him to extend backwards towards me as far as he can go. We're going to have you laterally flex to the right as far as you can go, laterally rotate to the right as far as you can go, just like that. All right, you can relax for a second. This test is looking for 3 different things. If he has point tenderness, 1 finger breadth lateral to the spinous process, it could be facet joint dysfunction. If he has pain at the PSIS, it could be SI pathology. And if he has radicular symptoms that follow the pathway of the nerve root, it is nerve root compression, which could be because of a space-occupying lesion, all the stuff that I've said before. That's everything.
Single leg stance test.
All right, single leg stance. Let's have you turn. Let's face this way. So single leg stance test, his feet are going to be shoulder width apart. His hands are going to be on his hips. If I am testing and my position is going to be behind him, if I am testing the right side, what I'm going to ask him to do at first is to just actively flex his hip a little bit, just to get it up off the ground. Right up your left one. So you're going to stand on your right leg. Yep. that's fine. If it's easier to describe 90-90 position, you can do that. I'm helping him with his balance. Then what we're going to do is extend backwards towards me as far as you can. And I'm gonna help stabilize him. All right, then you can go ahead and relax. So if he has pain, turn this way for me. If he has pain, 1 finger breadth lateral to the spinous process. And in this case, it would be on the right side because I'm testing the leg that he's standing on. That is a positive finding for pars interarticularis fracture, one of your spondies. If he were to have pain over his PSIS, that could be indicative of SI pathology. If he had, this test should be done with him first standing on one leg, then we would have him standing on the other leg. If it turns out he just has pain on the one side, the leg that he's standing on, it's more suggestive of spondylolysis. If he has pain from this test when he's standing on both legs, it's more suspicious of a spondylolisthesis, which is the displaced or decapitated Scotty dog.
I have a question. On this one, I roll against you and then you find overpressure. Is that not?
So, yeah, overpressure is okay. I may have said that I was helping him with the balance get into the end, but yeah, overpressure, because he's gonna stop here. I'm like, no, I want you to get to the full range of motion. So overpressure, both for this one and the quadrants. Yep.
Hoover test.
Hoover?
Hoover.
Yeah. All right. Lying supine. Talking to my kids about this test. I said I'm going to find ways to make sure you're not lying supine. All right. This is a test that is solely used to determine if the patient is not being truthful with me. It's called malingering. So when would I use it? I would use it under the circumstances that previously I have asked him to actively flex his hip. His leg just stays there and he says, no, I can't move it. And I'm like, I think you're lying. I think you can. So to perform the test, he's going to be supine. Clinician's going to come down, going to passively flex both hips just so his calcaneus are up off the table. Then what I am going to do is ask him to actively flex the hip of the leg that he says he can't. So in this case, we'll say it's his right leg. I'm going to ask him to actively flex his right hip. So, normally, what would happen prior to him attempting to lift this leg, he has to counterbalance his body, so he first pushes down with this leg before this one can be lifted up. So a positive finding is, when I ask him to lift this leg, if I do not feel him pushing down on the opposite side, he's lying to me. Bad patient. This is not something that's telling me that you have ABC condition. It is telling me that he is being less than truthful about what is going on with his condition. I think that's everything. Yeah.
Brachial plexus traction.
Brachial plexus traction.
Yeah.
Okay. Come down here, Elzar. You can sit in this. Sit, you'll face that way, yep. So he's going to sit, he's going to be in good upright position. One of you will get points off on one of these tests because you failed to say that prior to initiating this test, you have to rule out the presence of a cervical fracture or dislocation. So that's been ruled out. He's in a nice upright posture. My position, I'm behind the patient. I'm going to test his right side. I'm going to put one hand on the superior part of his shoulder, the other hand on the lateral side of his head, and I'm going to laterally flex his head and neck to one side while I'm simultaneously depressing the shoulder on the same side. This is a test for like neuropraxia, burner, or stinger. I'm checking for pathology to the brachial plexus. As I'm doing the test, if he describes radicular symptoms down his right arm, that is due to a traction or a tensile force to the brachial plexus. I'm doing the same test. He's describing radicular symptoms going down the left side. It still is an irritation of the brachial plexus, but it's due to compression of the nerve roots on the left side.
Shoulder abduction test.
Okay, shoulder abduction test. I'm going to do this with him seated, although I suppose it doesn't matter. Clinician is going to be off to the side. Now, why would I do this test? I would do it because my patient is describing neurological symptoms going down his right arm. And I am suspicious that the reason he has it is because the weight of the arm is creating a tensile force of where it is, the nerve roots are either exiting the intervertebral foramen or possibly some occlusion in the thoracic outlet region. Most likely it's going to be the intervertebral foramen. So how to perform the test, I'm going to ask Edelsar to simply take his hand and actively put it on top of his head. So just bring it up there, put it right up there. He just has to hold it there, 30 seconds would be fine. A positive finding here is the reduction in the neurological symptoms, and it's due to the fact that the tension that was irritating the nerve has gone away as the nerve is relaxed by him putting his hand on top of his head. You can relax. You may also find that sometimes patients self-identify when they're having all this problem, that they found a comfortable position, so they leave their arm up. That's just ancillary as part of your evaluation.
Cervical compression test.
All right. Patient's position is going to be seated with a good upright posture. You do not perform this test until the presence of a cervical fracture or dislocation has been ruled out. Clinician is going to go ahead with his eyes straight forward. Maybe have just a little bit of extension. Clinician interlocks their fingers on top of his head, and what I'm going to do is provide a downward force or an axial loading force through his vertebral column. So, what dictates a positive test? If he has radicular symptoms coming down one of the arms, that is due to the fact of nerve root compression as it's exiting the intervertebral foramen, and that could be due to a space-occupying lesion. So, positive finding, neurological reproduction of symptoms. This is nerve root compression. If he has pathology 1 finger breadth lateral to the spinous process, and it's localized, it's not moving, then that could be a facet joint dysfunction or facet joint pathology. I think that's it.
Sperling's test.
Sperling's test is an enhancement of what we just did. He has his good posture that we're talking about. I have ruled out the presence of cervical fracture or dislocation. This time, I am putting him in much more of an extension position. Then I am going to laterally flex him to the end point of his range of motion. I interlock my fingers, I push down on the top of his head. You can relax. Positive finding is the same as what we had before. If he has radicular symptoms, reproduction of the neurological symptoms, that is compression of the intervertebral foramen, space-occupying lesion, and as you might think, by him laterally flexing, it's going to shorten it even more, so this test would probably be more positive than the previous one. Although it doesn't really state it much in the book, because it's a similar test to before, if he has localized pain, exactly 1 finger breadth either side lateral to the spinous process, he could have facet joint dysfunction.
Cervical distraction test.
All right. This one, let's get you up here supine, feet down there, head right about here. Go down a little bit closer, just so you're comfortable. Okay. So, patient's position is supine. I am at his head with, first, you always rule out cervical fracture dislocation before doing this. Then in this position, with the one hand that the camera may not be able to see, I am underneath his occiput, so the base of his skull. It's giving me a good grasp so I can pull. With my other hand, I'm going to go ahead and grasp over his forehead. He might be in very slight extension, neutral is okay. How to perform the test, I am going to attempt to distract or pop his head off. I'm really going to pop his head off. I'm just going to distract here a little bit. I'm just going to rest you here as I talk. So, what is this looking for? This is looking for nerve root compression due to a space-occupying lesion with all those different causes we talked about. And a positive finding is he has to have these symptoms first. So before I begin the test, he's describing the symptoms. And then as I distract, I'm creating more space in between each vertebrae, so the compression that existed has now been relieved. So the positive finding is the neurological symptoms are relieved, which tells me that he did previously have the nerve root compression.
Adson's test.
Adson's, all right, you can stand up. We'll have you face that way. I'm right-handed, so I'm going to move over that way just a little bit. Okay. Patient will be standing. I will be alongside. First thing that I'm going to do is I'm going to take his radial pulse. So I'm going to take his radial pulse. Then what I'm going to do is abduct his arm 30 degrees. I'm going to extend his arm. I'm going to externally rotate that humerus. What I want you to do is laterally rotate your head to the right. Rotate it, there you go. Now extend your head and neck back towards me. Take a deep breath in and hold it. All right, you can relax. So, what I'm doing after he has held his breath, so he's, I'll just say, two things I'm looking for. The first thing is going to be a diminished pulse. And by diminished, I don't mean the heart rhythm of it is slowing down. I mean the intensity of the beat that I feel has been softened because of the occlusion of the neurovascular bundle. So that's one positive finding. The other could simply be the reproduction of the neurological symptoms that he's having coming down his arm. A couple things I'll add about this. So it's for thoracic outlet syndrome. And it's due to either a tight anterior and middle scalene and or a tight pectoralis minor muscle. Now, the way I remember that it's the Adson's test is that he's turning his head, so he's adding it to the side that's being tested. This is also the one that you're taking a breath, so you're creating tension both superficially by stretching out as well as internally by breathing in, expanding the chest. So that helps me remember it's maximizing what I'm testing, both the scalenes and the pec minor, if that helps you guys at all. All right, I think that was everything on that one.
Allen's test.
Allen's test. All right, so Allen's test, also for TOS, patient can be standing, I'm alongside. First thing that I'm gonna do is once again, take his radial pulse. Then I'm gonna put him in a 90-90 position. So flex your elbow to 90 degrees, flex your shoulder to 90 degrees. Then what I'm going to do is externally rotate his humerus, and that'll pull him into some extension. Now I want you to laterally rotate your head to the left, as far as you can go right there. All right, now I'm feeling for the pulse again. You can relax. Positive finding is, one, if there's diminished pulse, and again, I'm not talking about the rhythm, I'm talking about the intensity of the beats. Second thing could be a reproduction of the neurological symptoms that come on. And how it helps me to remember which test is what. When he has his arm up like this, it's kind of the letter L, which is the Allen's test, as opposed to the Adson's test when you're adding it. Oh, so this is for TOS. And the structure, the specific structure that's doing the occlusion of the thoracic outlet is your pec minor.
Military brace test.
All right, military brace. Let's have you face that way so I can see this one a little bit better. Patient is going to be standing, feet shoulder width apart. I'm going to go ahead and take the radial pulse. Then what I'm going to ask him to do is to kind of stand at attention. So just kind of stick your chest out a little bit, just like that. I'm going to abduct his shoulder to 30 degrees. I'm going to put him into extension, but I'm going to block his shoulder here so I don't kind of pivot or turn him as I do this. Last thing that we're going to do is I want you to turtle your neck. So take your chin and try and tuck it back towards you. You can look up a little bit, just like that. So that's the positioning. You can relax. I'm checking for the pulse. Number one, if it's diminished. Number two, reproduction of symptoms. This is for thoracic outlet syndrome, and it's due to not muscle, but a costoclavicular compression. So costo is rib, clavicle is clavicle. It means the bone is doing the compressing.
Ruse test.
Ruse test. You can face the camera. Standing or sitting doesn't matter. Where I'm standing or sitting doesn't matter either. But I want you to get into the 90-90 position. And then what I'm going to ask him to do is open and close his fist as quickly as he can for 1 minute. 58, 59, 60. He can put it down. What I am looking for here is, this is for thoracic outlet syndrome. We do not know explicitly what is causing the compression. All this is doing is confirming that he does indeed have TOS. Since I'm not feeling his pulse, that is not a metric that we use. The only true positive finding is the reproduction of symptoms as he's doing this. Or he had to stop because of specific symptoms as a result of doing this. Not that he's just tired, it's like my arm went numb and I had to stop. That's reproduction of symptoms, why he stopped.
Vertebral artery test.
All right, lie supine, feet down there, head down here. All right, I'm gonna be at his head. This time you do have to come a little bit closer to me. So I got you, so you can relax. It's on my knee right now, you're not gonna fall. So that's his position, this is my position. How to perform the test. I'm gonna let him, actually come a little bit closer. I still got your head up. Just relax. Okay, I'm gonna let him go into a little bit of extension. He has to keep his eyes open. Then I'm gonna laterally rotate him to one side. I'm gonna hold this position for 30 seconds. After that, I would go ahead and do it on the other side, hold him for 30 seconds. I'll let you get up or relax so you don't have to hold your head, you can sit up. So what is this a test looking for? This is for occlusion of your vertebral artery. Positive finding would be nausea, confusion, dizziness, altered pupil size, and or nystagmus, which means uncontrolled pupil movements. So if he has any of those, it's suggestive that he has some type of occlusion of his vertebral artery.
Babinski's test.
I need a foot.
Soccer or something.
No socket, preferably. Yeah, I'm gonna have to do it this way because I'm right-handed here. All right, so I need access to the bottom of his foot. And what I am going to do is I am going to go ahead and with a semi-blunt object, I'm going to start at the calcaneus and I'm going to draw a C going to the lateral side of the foot and then back over to his toe. So when I did this, you can see a little bit how he has the curling of his toes. I don't have to do it very hard. That is normal. What should happen is his toes should curl. A positive finding is his big toe extends, his other four toes splay, and that is the result of a upper motor neuron lesion to the cord or the brain. It's important to note that in newborns, this reflex is reversed, but shortly thereafter birth, it returns to what we saw right here.
Oppenheim.
Okay, I'll have you long seated here if you want to put your sock right there. No, I need your toes, sorry. All right, patient is long seated. Clinician is off to the side. Just pull up a little bit more. This is also for an upper motor neuron lesion. I'm going to identify the tibia, and I'm going to be just medial to it where I'm taking my blunt object and running it on the medial side. If he has an upper motor neuron lesion, he will have a hypersensitivity to this motion, and his big toe will extend and his other four toes will splay. It's possible that he could curl his toes, which is the normal response, but people just generally don't do that from just the light brushing along the tibial shaft.